Hi, everybody. We're going to have a very short conversation, very simplified conversation about hepatitis C medications. And I pulled this apart because there have been absolutely remarkable advances in HCV drug development over the last few years. The goals of many of the regimens that hepatology and gastroenterology use um, are really the goals for those regimens have been to increase sustained virologic response. You'll see that listed in literature as SVR rates. Improve tolerability, tolerance, being able to tolerate these medications in the past were very hard for patients. We're really looking now at eliminating interferon and ribavirin, which were the mainstays of treatment only a short few years ago. And then really looking at shortening the duration of treatment. 12 to 4, we checked people at 12 weeks back in the day. They were on these drugs for 48 weeks. But we're not doing that anymore. Improving convenience of the regimen administration, making it just more, again, tolerable for patients, and really zoning in on really looking at their exact presentation and tailoring the medication towards that patient. So there's been so much that I feel like you at least have to kind of know where Hep C medications are going, because even if you were in school 5 years ago, it was very different than where it is now. By no means are you going to come out of this short presentation feeling comfortable prescribing these meds, nor should you. But you're going to have patients on them, and you just have to at least know the names and just the very basics of them, and that's all I'm really going for here. So just some very basic elements to consider in patients with hepatitis C who perhaps you send off to either infectious diseases or gastroenterology hepatology is that we always want to know what their liver status is. So there'll be a whole workup looking at their liver, breaking down what kind of genotype this patient has. All hepatitis C management is now based on what genotypes they have. Are they genotype 1, 1A, 1B? Are they genotype 2, 2A? Are they genotype 3? And the list goes on. And it's broken down within the number. There's letters, 1A, 1B, to even further determine the management that we know might work best for them based on their genotyping. It matters if the patient has been treated previously or are they what we call treatment naive. That's a whole other consideration as well. And then we have to think about what are their other medical conditions, such as are they co-infected with HIV? That presents a whole nother element. But certainly it's not just HIV. All other medical illnesses need to be considered because of side effects and things like that. We're not going to dive into it beyond just what I have here on this slide. I just want you to understand really, truly, in the gastrointestinal GI world, hepatitis C management is probably the thing that is hardest for almost everyone to manage. And it's truly a specialty within a specialty. So when people talk about having failed treatment in the past, a lot of times what they failed is PEG interferon and ribavirin. Perhaps they've also failed protease inhibitors in combination with PEG interferon and ribavirin. Those are the medications that were being used about 10 to 12 years ago. They were the mainstay of treatment, but now we have many other regimen options, and I'm just going to go through some of those names with you. They're combination drugs, just because I want you to have an understanding that when you see patients coming in, whether it be hospital or office settings, that you at least just have some basic understanding of why these drug combinations are being utilized, and that you don't feel completely kind of thrown on what these meds are. Again, we're not going to dive deep into this today. The idea is that you're not the one prescribing these drugs. Because regimen options can get so complicated, because again, we have all those considerations. Does the patient have cirrhosis? How bad is their cirrhosis? Does the patient have co-infection with HIV? Does the patient, obviously, first and foremost, have ever been treated prior? Or are they naive? And then on top of it, are they genotype 1? Are they 1A? Are they 1B? Are they genotype 2 or 3? And the list goes on. That I just decided to give you an example of some of the newer medications for genotype 1 patients. And the crossover for genotype 2 and 3 is pretty even. And so I just decided to leave it with these 3 slides because these interferon-free regimens that are listed in the next 3 slides are really the newer agents and the combination agents. So I think you'll get an idea of where sort of treatment is headed. And that's all I'm trying to do. So our interferon-free regimens, and again, these would be the ones for genotype 1, but they're also utilized a lot of times for 2 and 3, are things like Harvoni. You've probably heard of Harvoni. It's a combination agent. It has cure rates of about 94 to 99% for treatment naive and treatment experienced patients. Even for patients who have cirrhosis, they can take this medication with that level of success. That's unheard of in the past. Harvoni came out, I'm going to say about 10 years ago, give or take, and it really changed the way that we managed hepatitis C. It's a 12 to 24 week duration of therapy, and again, success rates are very good. When I say success or treatment success, I mean that the virus is undetectable, very similar to how we say success with HIV patients, that with our best testing measurements, we cannot detect the virus post-treatment. So with all these medications I'm going to go over, they say don't use rifampin, St. John's wort, amiodarone, and if possible during treatment, don't use them. And then use low doses of acid reducers as well on these treatments because it can kind of decrease some of the medication value. But again, we do our best with that. So again, additional combination regimens are things like Epcolsa, and I'll just give you an example. So I'm trying to give you sort of different things on each medication. So here I'll just tell you, like it's 400 milligrams and 100 milligram, and it's a tablet. These are all tablets for 12 weeks. The next one is Mavyret, which I think you'll hear more about with your patients than Epcolsa. You'll hear Mavyret and I would say Harvoni being the number one. But Mavyret you'll see a lot of, and I'll just give you an example. So what are these medications? So Mavyret is a combination of an NS3 and NS4A as well as an NS5A inhibitor drug, and most of them are. These are 12 to 16 weeks, similar side effects as Humira. There's also some concern with cyclosporin and other antiviral drugs when using Mavyret. You can use Mavyret in early stages of cirrhosis, but if patients are moderate to severe cirrhosis, we can't use this drug. And that's important because a lot of our patients obviously are. Zepatier is another medication, interferon-free regimen, and it's again 12 to 16 weeks, and that range gets determined by many factors and similar medication side effects as well as indications as Mavyret. And lastly, I'm just going to show you an example of now what's happening with the newer agents. And I could show you 4 or 5 different combination options, but I don't think you're going to see these very much yet. We're still having problems with drugs like Harvoni being covered by insurance. They're extremely expensive. Harvoni was not covered at all in the beginning. It was hundreds and hundreds and hundreds, thousands of dollars. Now Harvoni is getting covered quite often. Now we're seeing a little bit more Mavyret being covered. And some of the ones I just mentioned on the last slide, haven't gained as much popularity in terms of the insurance companies covering them. So that's why I'm not going to go through all the examples of like what I have on this slide. But what you can see here is now the newer combinations of drugs, which you will see in your lifetime, are several combinations of antivirals. So we were seeing in the prior listing of meds a lot of antiviral NS3 inhibitors, NS5A inhibitors, and now they're doing something even more. They're adding in ritonavir, um, which is a PK enhancer. That's a CYP3A4 and CYP2D6 inhibitor. So the drugs went from being 1 to 2 agents, PEG interferon and ribavirin years ago, to then being 2 and 3 combination antiviral inhibitors. Now they're adding on PK enhancers. And in addition, this medication, for an example, a lot of times can be given with or without ribavirin. So it's just really zeroing in more and more and more on exactly what they're trying to target. And they're targeting based on genotyping and based on really pretty impressive serologic markers for these viruses. This is similar to HIV treatment. It went from being really broad-based, kind of really just go after the kitchen sink, right? Just pour these medications on patients, not really being tailored antivirals, to now these antivirals, whether it be Hep C or what we talk about with HIV regimens, they're so tailored that patients, one, are doing really well with them, and the side effects are so much less. In the case of Hep C, treatment duration is much less. And so that's the benefit of these drugs. The downside, still expensive, very expensive. So that's what we've got to kind of get a handle on next. But you will just be seeing the more and more combination drugs down the road with all of our quote unquote viruses. Okay, hope this helps.